I just wanted to go over a little tip that I recently learned that helps with actually placing the tube in a patient's airway. And I find it's particularly helpful in situations that new learners and trainees find themselves in fairly frequently. And that's when you have a good sense of where the airway is and you have kind of partial visualization of it. You ask for the tube and you begin to place it in the mouth and down through the back of the pharynx to the larynx, but you can't actually manipulate the tip of the tube into the airway. And I find this is most helpful in situations where you have a grade 3 view. So if I can draw a little airway here. So this is your epiglottis, kind of coming out there. And you get a sense of where the airway is. It's here, but you can't actually see the cord. So your laryngoscope blade is in the vallecula here, and you're lifting up. You're doing that with your left hand. You're lifting up. You're lifting up with your laryngoscope and out about 45 degrees towards the opposite wall of the room. But you aren't able to actually visualize the chords themselves. So that's what's kind of typically classified as a grade 3 laryngoscopy view. So in this setting, if you have some experience and confidence, you may still ask for the tube from your helpful assistant. And I find that oftentimes with new students and trainees, as I pick up my tube here, they start passing the tube into the mouth, and they kind of get stuck down here, and they're not able to manipulate the tip of the tube up into the airway, or sort of anterior into the airway. Now there's kind of several different things you can try. One is kind of corkscrewing it, so kind of turning the tube to its side and trying to kind of turn it up into the airway. That can cause some amount of trauma to the airway, and I've found it actually not that successful. You can try kind of turning the tube on its side and trying to kind of manipulate the tube like that. But this trick that I recently learned that actually seems to be quite helpful so far is actually changing your grip on the tube slightly. So instead of like you're holding a pen, you can kind of change it so that you're using all your fingers. You've got your pinky finger on the inferior side and your other 3 fingers on the other side, the superior side, and your thumb kind of as a lever here. And what you do is when you get the tip of the tube to the point where you can't move it anteriorly anymore, you just use the leverage of your pinky finger and your thumb off of the other 3 fingers to just flex it. So you flex the tube so that the tip just kind of pops anteriorly, and then you cock your wrist so that the tube just kind of pops forward. So again, flex anteriorly and just drive the end of the tube forward. And I found that actually quite helpful in situations where I have a grade 3 laryngoscopy view and I can't manipulate that tube anteriorly. So give that a try if you find yourself in a situation where you know where the airway is, but you just can't seem to get the tube moving anteriorly. It may help you out, and it may avoid a situation where you have to give the intubation over to your staff.